And welcome to the first town hall of the 2021-22 school year. We thank you for coming, and we also want to say thank you for all of the questions that people have emailed to covid-19@vssna.org prior to our meeting. The contact tracing questions that were submitted will not be addressed today. They will be addressed next week at our town hall on Thursday, August 26th from 4 to 5 p.m. We will be joined next week by Julia Pringle and Shannon Stem from the epidemiology department, and they'll be presenting on the contact tracing and the OPR process for schools this school year. I want to thank and introduce our speakers today. We have Dr. Becca Bell from the Vermont chapter of the American Academy of Pediatrics, and Dr. Bill Raszka, who's our infectious disease expert from UVM. They will be sharing information about COVID and the variants, as well as going over the updates to the pediatric algorithm today. So without further ado, I'm going to turn it over to Dr. Bell and Raszka. Thank you so much for being here.
Well, I'm Bill Raszka. I'm the pediatric infectious disease physician at the University Medical Center and Children's Hospital. And I recognize some of you. Some of you have seen before. We've chatted, we've had discussions. I think Beth, I know I believe you have a relationship with someone who is a superintendent, and we've had many interesting and robust discussions. So it's great to see you. This is going to be very informal. Becca and I are here to help answer any questions. As you know, that you cannot open CNN, New York Times, Wall Street Journal, The Digger without something about the Delta variant, something about COVID, something about schools. It is what I like to say, a remarkably fluid environment. And just as the disclaimer, some of the things we talk about today may be quite different by Monday. And our goal will be just to have a continued conversation. We look for your advice. We know how integral you are to the care of children. And we look at this as a collaborative effort. And before I launch into our slide procession, I'll let Becca make a few remarks, and then we'll just go talk about a little bit some of the emerging science.
Welcome, everyone. And we're excited about the school year coming up, and just wanted to be able to provide some information about Delta, our thoughts about the upcoming school year. I do want to just start off by saying there are a lot of headlines, obviously, about Delta, and in particular, Delta in children. And in Vermont, I think we're set up to have a good school year. I'm a pediatric intensivist, so I take care of the sickest kids in Vermont, and I'm feeling like I feel confident we can have a good school year. And we'll talk more about that in detail, but I just want to set the stage that there are parts of this country where people are really overwhelmed with pediatric cases, and we are not in that place. And I'm feeling really good about the school year.
All right. So all of you should be able to see a large white screen. And checking the sound. Becca, is the sound okay? Excellent. All right. So we will try to go through the slide set. As I mentioned before, this is informal. Any comments that you have in the chat box, we'll try to answer. If we can't answer it during this session, we'll make sure we get the answers to Becca and Soph at a later date to make sure all the questions are answered. So we can't do an educational session without some objectives. So we're going to define variant. Turns out that's not as straightforward as it sounds. We're going to review variants of concern. We're going to do a little bit about vaccine efficacy and effectiveness because they're slightly different. And we're going to review the status of COVID-19 vaccines in children. We're not going to talk about boosters at this time, though if you have questions about them, we could potentially do that because you can imagine that there are some teens who are eligible for the third dose of the vaccine. So I always like to begin with some definitions just to make sure that we're all talking about the same thing. And there's a really difference between a mutation and a variant. A mutation is a very specific permanent alteration in the genetic sequence. So one single thing is different about that ATTACC, and then we can track these mutations and we can give them a name. So we may call it this N501Y, and you'll see that in the newspaper periodically or on the web, but that's a specific mutation. And you can imagine that the SARS-CoV-2 can have lots of different mutations, lots of them. A variant is simply a group of coronavirus that share the same inherited set of distinctive mutations. That means that the variant has the same package, that has a package of mutations that are relatively consistent. And this lineage is a branch of the viral tree. What's happened in the literature is that variant and lineage have become synonymous. How important is that to you? Probably not. This is me being geeky. I'm an ID doctor. This is what I do continuously, but they are used synonymously and will continue to use that. And the strain is, a lineage as it evolved really different properties. So as you know, there are lots of coronaviruses. We've been wrestling with coronavirus for a long time. The common cold, usually one of several coronaviruses. But now we have SARS-CoV-2, so it's slightly different. So this would be the genetic tree. So we have coronaviruses, and then we have the Middle Eastern respiratory virus, what's a coronavirus. And then there's the original SARS, which many of you heard about in Hong Kong and in Canada. And then you can see this is an old slide, it's called Wuhan, but this is where it emerged, okay? But these are all coronaviruses, just say, we can really separate them. So SARS-CoV-2 is a coronavirus that acts very differently from other coronaviruses. So the CDC publishes a list of variants of concern. Now, why would we be concerned about a variant? Well, you intuitively know why we'd be concerned. If it's more infectious, you don't like coronaviruses that are more infectious. It means that more people develop infection, more people could potentially develop disease. Another thing would be really concerning would be if people develop more severe disease. So you will see over and over again, discussions about whether or not the Alpha variant, which is the one that emerged in England, caused more severe disease. Over and over again, you're seeing headlines over the past 2 weeks. Does the Delta variant cause more severe disease, particularly in children? So again, infectiousness and severity of disease are two of the principal drivers of variants of concern. We also worry about variants that escape immune detection or control. So I'll give you an example of that. You have an infection with coronavirus, you develop what you think is a protective immune response, but a new variant comes along, and guess what? You can get infected again. You're not protected against it. So that was actually very concerning. Some of the mutations that have given rise to some special variants seem to be less likely to be controlled by pre-existing antibodies or less likely to be neutralized by pre-existing antibodies. Turns out the variants you could worry about if they interfere with diagnostics. Let's say you have a variant that the PCR does not easily detect. That would be really problematic, or be resistant to antiviral therapy. So it turns out that is not, we don't have variants that are resistant that we can't detect by PCR, and we don't have much in the way of antiviral therapy. I would not put a lot of stock on remdesivir, just a little FYI, but so that's not the issue. I would say the nomenclature is incredibly confusing. Nobody in virology understands the nomenclature. They really don't. So remember, there was the P117, and then there was the South African strain, and basically it's devolved to Greek letters. Now, somebody's going to be really upset with this slide because we have to be really careful about assigning a site. And I put it down here just because it just helps us to understand which variant we're talking about. These are so we now call them by their Greek names, alpha, beta, gamma, delta. Here is the typical virology nomenclature that's associated with them. And this is where they were originally reported. Keep in mind, we have to be very careful about this, that this is not a failure of South Africa at all. This is because the South African scientists were really talented and were doing sequencing very early and did a superb job. Even though this is called Brazil, that was actually first detected in Japan and Japanese travelers who returned to Brazil. But nonetheless, In the lay literature, it's often described as the strain that emerged in England, the strain that emerged in South Africa, the one that was in Brazil and India. But right now it's alpha, beta, gamma, and delta. And of course, a lot of the action is over here on that delta variant. That is what is circulating widely through the world. I would also say, interestingly enough, that the original strain that was circulating in the United States in 2020 was a variant. Keep in mind, the original strain that was identified in Wuhan disappeared quite quickly, and that strain was replaced by a strain that was much more infectious and emerged in Italy and spread through Europe and the United States very quickly. And that's what basically was the dominant strain in the United States in 2020. But this is what we're dealing with right now. Most of these mutations that we talk about are all about in the spike protein. You can see here, this is the classic cartoon. You have the genetic code in blurry pink stuff here. You got the nucleocapsid here, which is in this blue, and you got these spikes sitting out on the outside. Almost all the mutations we talk about deal with the spike protein, because that's what mediates the attachment to the receptors. And so when we talk about mutations, okay, this is from the New York Times. You have the coronavirus. You have, again, if we take this picture here, we cartoon here, here's the genetic code that codes for the spike protein. Basically, you have a mutation in the genetic sequencing, and it leads to some different conformation over here. And very technically, 3 spike proteins make 1 spike, but that's just not that important. But you can see you can have a little tiny, like you have this little tiny orange thing right here, a little tiny thing right here, but that can convey lots of differences that may make it more easy to bind to the receptor and the respiratory epithelium. There are some, and we're not going to spend too much time on these things. I just put it out there so that you, in case you read about them, these are some of the classic mutations that were circulating, that people were really worried about before this summer, because they were really well described in how they increased infectivity. And this is one that will continue to arise, and they call it the EEC mutation. And the reason why this will continue to be discussed, even with the Delta variant circulating, is that this mutation helps the virus evade certain types of antibodies. So both the beta and gamma variants, South Africa and Brazil, have this variation, this mutation, and Delta plus, as some people call it, have this mutation. So it just is concerning because it doesn't have to do with infectivity, which is primarily we're dealing with the Delta virus, but it may prompt some difficulty in neutralizing the virus. This is the Delta variant. So they have a slightly different package. This has been well described over here. This little thing over really makes it much more infectious, but this is just a cartoon of what the Delta variant is. And again, these things just, you know, we don't really spend a lot of time on the individual mutations. So let's do a high-level summary of what these means. Alpha variant, the one that emerged in England, was much more infectious than the dominant variant at the time. Remember, we heard about this, you know, last spring, you know, that there was 50% more infectious. It was 50% more infectious. The beta, this is the one that was in South Africa. I was concerned that you could infect people previously infected with other variants, and the vaccines seemed to offer less protection. The J&J and Pfizer data was somewhat reassuring, but this is interesting. The AstraZeneca vaccine, which is not approved for use in the United States, but widely used around the world, completely failed against that vaccine. Completely failed. Just shows you how important that particular mutation can be. And gamma is the same sort of thing as beta because it has the same mutation package. So again, the big issue is that they might be more infectious. They were a little bit more infectious, but they seem to escape immune detection. All right, the Delta variant. This is what has captured all the attention in the United States. And so we can track the variants. So you can see the World Health Organization label here, alpha, beta, gamma, delta. Look, there are several others. I hope we don't run out of Greek letters. Here's the lineage. This is the terminology, the confusing terminology we talked about here. And just talks about the percent, okay? But look what happened over time here. This B117 here, this is the alpha variant. This is in May. The alpha variant was the dominant strain in the United States in May. And look at this. Delta had this tiny little percentage. And look at this mushroom. Whoosh. Look, that's just amazing. Just rapid. This variant is just much, much more infectious. And when you're much more infectious, you're going to crowd out all the variants. You're going to crowd out everything else because you have a survival benefit. And so this is what we're seeing here. You know, when we look at our own internal data in Vermont, I think that, you know, in the month of July, I think only 2 of the variants that were 2 of the viruses that were sequenced were alpha, and the rest were all Delta variant. So what did that lead to? I think you're all familiar with this. You know, last January, oops, I didn't want mean to do that. We had a big spike, bada bada boom, lot more infection in children. That bada bada boom stuff is a very technical term, but there it is. You know, I mean, this is what's happened in children, and you can see that there's an uptick in cases everywhere. And people look at this and say, is this virus unique to children? I think what the issue is that it is highly infectious, and anyone who's non-immune is at high risk. And children, young people, are disproportionately non-immune, meaning that, remember, children under the age of 12 can't be vaccinated, and across the nation, relatively a very modest number of children, you know, 12 to 19 are actually immunized. So they're at great risk. And again, we didn't have a great uptick in the people between 18 and 35. So again, those are the target groups. If you're not immunized, you are at huge risk for developing infection. So it's not that worse in children, it's just children haven't had a chance to develop immunity due to vaccination. So what's my summary on variants? They emerge quickly. And if you're more infectious, you will soon dominate the scene. The more infectious you are, the more likely it is that you're going to dominate the scene. And that they're not stable. And that when you have 8 billion people in the world, and the vast majority are not immune, you're going to have pockets where the virus can emerge, and that we're going to have pockets in the United States where new variants will emerge just because we don't have protection. And so that we will always be grappling with variants, always. All right, vaccine development. All of you are quite familiar with the Pfizer-BioNTech vaccine and Moderna. These are mRNA vaccines. They've been licensed for use in the United States for some time now. Novartis, this is really disappointing. Novartis is also an mRNA vaccine. You think it would work great? Their data was terrible. It was only 60% effective. Not good. That's just dead in the water. You know, when you have vaccines that were 95, you know, to 100% effective against severe disease, and now you have one that's only 60%, that's not going to help. Very unfortunate. Very unfortunate. We have the viral vector vaccines. We have the J&J vaccine that's approved for use in the United States. The Oxford AstraZeneca worldwide used extensively because, again, this product is inexpensive and there's a commitment to provide it around the world. So it could be produced in a lot of different places. And there are some protein-based vaccines. Norovax is very interesting, and that has some good data, and that's based upon ancient technology. So just as a reminder, even though you have mRNA vaccines and viral vector vaccines, you got Pfizer, Moderna, you got your J&J, the bottom line is the same. They just kind of deliver it differently. The key thing is you're trying to get mRNA in the cell, in a human cell, viral mRNA in a cell, that you can now make these spike proteins, and the host immune response can react to that, and you can develop antibody to the spike protein, as well as cell-mediated immunity. So one is that you deliver mRNA protected by a lipid, the other is that you deliver DNA protected by a viral capsid that's uncoated mRNA made, but essentially the same thing as you're making spike protein in a host cell. Remember, these are non-replicative. We've discussed that before, but you can give these to immunocompromised patient, you're not going to have replication of the virus. And again, we haven't talked much about this. This is people are really excited about this, but this protein-based vaccine, Novavax, is designed similar to the HPV vaccine, the human papilloma vaccine, and the HBV, human hepatitis B virus vaccine. Essentially, you make billions of these little tiny spike proteins, billions, and they aggregate into a ball that has literally billions of epitopes of spike protein. And so that will be very exciting. And there's some emerging data that looks really good. All right. So what's the landscape for vaccines for 12 and older. Okay, so the first thing is 12 and older. We still only have the Pfizer BioNTech. And I cannot tell you how many times people have asked me, what happened to Moderna? You know, Moderna was only 3 weeks behind Pfizer. It is very unclear why we don't have emergency use authorization for the Moderna vaccine for teens. Very unclear. Nobody knows. You know, there are whispers, you know, but literally nobody knows because they accumulated the data. So we don't know. We hope, we keep on saying it should be soon. It should be soon, but I don't know why we don't have emergency use authorization for that yet. Now, it turns out in the United States, you know, we have a vaccine surplus. We have people who aren't, you know, we have plenty of vaccine available. But still around the world, this would be really nice. Interesting enough, J&J has data and teens, but I don't even think they've applied for the emergency use authorization. It could be they're going to do it all in one giant package. It's unclear. So again, for children 12 and older, we right now only have the Pfizer BioNTech product. How about vaccines for children 12 and under? You know, that is a large group of the population. They are not eligible for vaccination. And again, it gets this idea. Here's an interesting digression. You know, when do we consider the virus endemic? You've seen those discussions. They've played out. We've been discussing it for a long time. You know, my personal bias is that we shouldn't accept this virus as being endemic until every single person has the opportunity to be protected against it. And so that when we get the vaccine for under 12, will play a big role in that. So Pfizer and Moderna have been enrolling children for a long time. Pfizer initially said they will be ready to ask for emergency use authorization in September. They said that quite a long time ago. They sort of reaffirmed that 2 weeks ago, but the FDA asked them to double the number of children enrolled in their studies. And that's a little unclear what the doubling accomplishes, because they had 3,000 people in the study. And these are bridging studies, meaning that they prove that the vaccine doesn't have a lot of side effects. They prove that children have the same immunologic response or better than adults. Generally, children have better immunologic response than adults. And they say, well, if it worked in adults, it should work in children. And they usually have, 10 or 15 kids in one group who got the infection and none in the other. Literally, it was 9. And they go, yeah, it's safe. It seems to be effective too. But, when you double from 3,000 to 6,000, you're not going to see rare signals. Like when we saw the little bit of myocarditis signal in teens with the Pfizer vaccine and Moderna vaccine, that took millions of doses to detect that. So it's a little unclear what we're going to accomplish by that. Pfizer does say they do plan to seek emergency use authorization in children, young children under in September. Keep in mind, interesting enough, the dose will be different. This is a little bit deep in the weeds. The only reason I mention that in case the schools are involved in administration of vaccine for children under 12, because there is some plan to have some mass vaccination centers, school-based clinics, at primary care offices, and Becca can talk a lot more about that. But the dose will be a little bit different probably from the Pfizer vaccine. It turns out that the vaccine is so immunogenic in young children, they don't have to use as much. Now, one could argue, why not get a really high titer? But again, there's a worldwide shortage. So they will probably use a smaller dose in children 5 to 11, maybe 10 micrograms. Keep in mind, the current dose is 30 micrograms, and the young children will only get a 3 microgram dose. So it could be a tiny whiff of the vaccine. So instead of I think Pfizer is a 0.3 ml injection right now. So it could be that these children get a tiny injection, or they just dilute it a little bit more. J&J have enrolled children. Again, it's a little unclear when they're going to present their data for children under the age of 12. But I'd say a big issue is that go slow has a lot more momentum than I think some of us had expected. And the issue is that young children develop severe disease much less frequently than adults. So if they develop severe disease much less frequently, well, we should be really cautious with them. We have to be absolutely confident that there are no safety problems whatsoever, that it's not too reactive, that there aren't any complications. So many high-level infectious disease experts have said, let's go slow, or even we think we should get full approval, not just emergency use authorization, full approval for children. What the difference is that to get full approval for vaccine, you have to have 6 months of safety data. So those are the controversies swirling right now, and potentially why there may be some delay. So I don't really know how that will play out, to be honest with you. So those are the controversies. All right, vaccine effectiveness. What are the take-home points? Efficacy and effectiveness are different. Efficacy is in a trial. Effectiveness is what happens in the real world. They all protect against severe disease. The licensed vaccines in the United States protect against severe disease. That is a really important message that we can tell. That the vaccine program was designed to protect against severe disease. These vaccines work against severe disease in children and adults and with the Delta variant. That is a great take-home message. What we have heard about are breakthrough infections. They tend to be uncommon, although there is some signal that they're becoming more common, particularly in older people and particularly people longer from the time of their vaccine series. But again, we're protected against severe disease. Many people report that these breakthrough infections of mild disease are proof how effective the vaccines are. Because remember, the goal was to prevent severe disease. But nonetheless, it does lead to these controversies about, infectivity, infectiousness of people who have breakthrough infections, contact tracing, how infectious they are. But again, the goal was to prevent severe disease. But nonetheless, breakthrough infections do occur, tend to be very much mild disease, incredibly rare death. Like it's hard to measure it per 100,000. That's how rare it is. But they do have high viral loads, and so we have to think carefully. And that's why we're recommending, even in the era of vaccination in Vermont, where we have high vaccination, we can do mitigation procedures, and we should. So these are the hot spots across the United States. You can see that we look very different up here. I think yesterday we had, 85 cases or something like that. We do have like 20 people in the hospital. We've been running like 100 cases, but you can see we're very different from here, where hospitals are being overwhelmed, literally. The National Guard's being deployed in some of these areas. So COVID-2 in schools. It's amazing. Like this is so essential to your being. So here are my thoughts. Vaccination works. We have messaged that, we have emphasized that, we talk about it all the time. But again, we have to be clear that the vaccination program works, and that we should absolutely optimize anything we can do to deliver vaccines. And I'm hoping that as we hear about news around the country, that there'll be an uptick in adolescent vaccination. There is around the country, an uptick in adolescent vaccinations. Hopefully that they'll be seen here as well. Again, because it's a 2-dose series, not everyone will be protected before school begins. But again, just getting people shots in the arm. Mitigation strategies work. We proved nationwide, we proved around the world that mitigation strategies work. Vermont led the nation and basically in proving this works. I mean, we had a great strategy. Again, it's a 3-part strategy. Do not let the virus into the school. You know this as well as I do. People who are sick should not enter the school. That's a really effective strategy. Screening, at the front of the door is not a particularly effective method, and that has largely been disbanded most places. But again, we should, children who are ill should not go to school, and children who are ill should be tested. If you are ill with signs and symptoms, you should be tested, and you shouldn't enter school until you have a test result. Prevent transmission of the virus in the school. That's primarily masking. Masking. We have proof that masking works. How many of you saw influenza last year? Nobody. We only saw RSV and rhinovirus this summer when everyone stopped masking. We saw little disease. We saw little COVID, no influenza, no RSV last winter. Masking really works. That is the primary mitigation strategy for schools. If everyone's masked, then the distancing is not so critical. Notice the guidelines don't really talk about distancing unless you're unmasked. Distancing will be important, I believe, when you take off your mask to eat. But if everyone's masked, then people can congregate. And again, remove sources of infection in school. You're going to talk about this next week, but Vermont is still committed to contact tracing. And they'll discuss more with you about how they're going to do that. But again, you want to get those people out and then find those people who are potentially exposed. But the big issue will be masking. So again, we've talked about this no ill children in school. There is a mechanism that will be discussed later on, sort of routine surveillance, that there is that schools can sign up for that you can test children. There are some issues associated with that because we're going to do anterior nares, and most children can do their own anterior nares, and there's no real PP needed for that. A trickier thing will be if you have a young child who can't do their own anterior nares swab, who's going to do it? My personal bias is I do not want to consume nurse resources. That's an incredibly valuable resource, but I can imagine that under certain conditions, if the mother or father or guardian can't do it, that you might be called upon to do that. It's unclear. And again, we have to decide what are the protection, what's the PPE necessary, and again, depending whether it's inside or outside. We're going to, again, continue to emphasize preventing transmission in school. And again, we highly recommend masking. You notice that guideline came out that schools should require. It doesn't say that the Agency of Education didn't say we will require. It says this is up to the schools to require. So there's some real interesting legal language there. But again, I think Becca and I are in firm agreement that masking is essential. That we've tried to enhance ventilation, but we're not going to make that a hard stop. And again, distancing when not masked. And again, we talked about some of the contact tracing, which you're going to spend more time on next week. So I'll stop there. You always have to be careful when you let an infectious disease doctor talk, because we love talking forever on virology, but I'm happy to answer any of the questions that you may have, or if there are any hot button issues, Soph or Becca, that I should address now in the chat box.
Bill, I can address, I looked at some of the questions as they rolled in to give you a break, and you can add to my answers. So there's some questions about, I think I might actually start with Kelly's question about what are your thoughts around media focusing on and telling the public how more younger children are getting sicker with COVID? And that leads into a few other questions about severity of illness in children and what we're seeing in children. I would say, we have a huge challenge right now and always through the pandemic, but I feel like it's getting even a little bit more, there's even more tension around how to talk about COVID. And so I will share with you, and I'm sure you're seeing the same thing in your communities, talking to families, that we see children that have real pre-existing conditions that could make them high risk for COVID. And their parents aren't interested in vaccinating themselves. They're not going to be interested in vaccinating their child. And we're doing a lot of counseling saying, this is a vaccine preventable illness. You really should get vaccinated. And they're not masking or doing anything. And then on the other end of the spectrum, we have families that are very anxious and very apprehensive about the start of the school year and very worried that they're sending their child, into the lion's den. And so we've got folks just on that spectrum. And so, thinking about how to talk about this can be a little bit of a challenge as like a broad message, because people kind of need to hear different things. Generally, we're now at the point where this is a vaccine preventable illness, which means when you have something that's preventable, it feels more frustrating when people are still getting sick with this. So we are, really telling everyone this is serious enough that you should vaccinate yourself. You should vaccinate your children when they're able to be vaccinated. We should take it seriously, and we can prevent it. On the other hand, the places where hospitals are being overwhelmed with pediatric hospitalizations are not in this region. So if you can imagine, we have parts of the US communities with very low vaccination rates, which means Delta just has tons of places to go. It's infecting, unvaccinated adults are getting sick and getting admitted to the hospital. That's stressing that hospital system. And then of course, unvaccinated kids are also getting it. Then that's doubly stressing the hospital system. So now you've got hospital systems where you've got a lot of adults and a lot of kids, and you're running out of resources, and the staff are getting COVID. And so it's like this built up pressure that's very overwhelming and very scary for people that I know that are working in these areas of the US. We are sort of on the other end of that spectrum where, it's great that we have a high vaccination rate. But we still want to do the things that we can do to protect people. And heading into the school year, we want to use these mitigation strategies. So I think always a challenge with how things are covered is that people are going to take what they want to take away from it, and they're going to hear different messages. The question about whether the Delta variant is more severe is still, and Dr. Raszka can correct me, it's still not clear. So, the question, what is definitely true is that a person, like I'll give an example. I have children who are too young to be vaccinated. So my children are more likely this year, during the school year, to get COVID than last year because there's a more transmissible virus circulating. However, we don't know for sure that if they had gotten, say my kid got COVID a year ago versus they got COVID today, that they would have a more severe course. The data is not really there yet. What's happening in places where there's lots and lots of kids are getting sick, a percentage of those kids are going to have severe disease. And so that's stressing the hospital system. The other, just in terms of pediatric hospitalizations that Dr. Raszka mentioned, is that we did not see RSV all year. And then we started seeing it this summer, basically as masks came off, and the South was hit with RSV before we were, and they are really also overwhelmed with RSV hospitalizations. So that's adding to the stress of the hospital system. So yes, it is when the media covers, Louisiana, Mississippi, and Florida, and Texas, and saying like people are out of ICU beds, that is true. But there's sort of a confluence of factors there. So that's the story on pediatric hospitalizations and severity of disease. So it's more likely that a child will, if exposed to the virus, will get infected this year than last year. But I wouldn't say that a COVID infection in a child this year is going to be necessarily more severe compared to last year. Okay, so, and then I'm going to talk a little bit about the masking question because this is sort of on everyone's mind, and just to kind of give you the lay of the land. So my other, I work in the ICU here. I'm also the president. I'm the pediatrician's Becca McCrae. So I'm the president of the Vermont chapter of the American Academy of Pediatrics. And so we've been pretty clear about what we recommend in terms of masking in schools. And as Dr. Raszka mentioned, it's a helpful and important mitigation strategy. It helps prevent the spread of COVID in schools. Also, RSV is around right now. We've got some RSV cases in the hospital, which means that when we're starting the school year, there are going to be some of these respiratory viruses that we generally don't see right away at the beginning of the school year. So, and when we talk a little bit more about the protocol and algorithm about staying home, RSV, all these, rhinovirus, all these other viruses are going to play a role in disrupting the school, school attendance because kids are going to have to stay home. So for all those reasons, we think masking is a good idea. And we definitely, made that clear to the administration. As you know, that there was a very different place last year where there was a state of emergency in place, and now that is gone. And so much of the authority, or really all of the authority, is coming now from like local school districts. And so the recommendation from AOE was that they recommend that schools require universal masking at the beginning of the school year, which we agree with. It's also what the CDC says, what AAP National says. Then a lot of people, and you of course, have these questions about what's this deal with the 80% benchmark. And what we've recommended is that everyone everyone just continues to mask universally, even if you've reached above that 80% threshold. And we do that, as someone noted in the chat, in the question, like, what if somebody has unvaccinated siblings at home? Like, we live in, even if you work or go to a high school, school communities are so tightly connected. You've got siblings and families and other folks around. So we've continued to make our recommendation that people universally mask. We also think there's a lot of practical challenges in taking off masks. And then the other piece is just that it doesn't, the vaccines for younger children, we don't know when it's happening, but it's around the corner-ish. And so it doesn't make sense to back off on mitigation measures when we've got folks in our community, these young kids who just haven't had the chance to be vaccinated yet. I think there'll be a different landscape when people have all had the opportunity. It's something we can revisit and look at levels. But for right now, that's what we're recommending. And so we have communicated with school administrators, the Superintendents Association, Principals Association. So they all know our recommendation and have passed that information on to the schools. We've had Dr. Raszka and others who've talked to individual school boards about this, because in different districts, it sort of depends on like who makes, who sort of has the authority to make the rules around masking. So we've made our recommendations really clear. And, I think we will continue to, even individually, to tell families, like, just keep, our recommendation is just to keep masking. So I'm going to pause there, Bill, and let you, I don't know if there are other questions that came up while I was chatting.
I've been busy typing. I've been listening with one ear and typing with my my fingers.
Can everyone see the chat? And then we don't probably need to read what Dr. Raszka is writing in the chat. I think I'll just let people read it. So then the other piece I'll just mention is about the algorithm. We were hoping to show that to you all today. We're still making edits to it, and so that is coming, because I know that this has been a really important tool to think about how to manage what's going on in the school. So this is the algorithm that's 2 pages. Last year was 2 pages, right? And so the first page was like, if the student has exposure to COVID, and then you look and see whether they have symptoms or not, and then whether the exposure was like a one-time exposure versus ongoing exposure in the home, and when they can return to school, at what point they test, et cetera. And then the second page was, they haven't had an exposure, but they have symptoms, and at what point do you test, and when do they come back? So we're updating it, and really we've, there's kind of 2 big changes to that, as some people have wrote in for in their questions ahead of time. One is that students who are vaccinated have an advantage here, which is this is like another way to talk about, the importance of vaccination to students and families. And that those who had an exposure will be able to continue to go to school as long as they don't have symptoms if they're vaccinated, and they'll have to test. And we have that all set out for you. We do still need, whether you're vaccinated or not, if you have symptoms, if you're sick, you need to stay home, get tested, and not come back to school until you're better. And we've laid all that out. So that's whether you're vaccinated or not. And the other piece around the testing is that, if you recall, last year at the beginning of the school year, it was harder to get a test. And we were sort of pointing most folks to their medical home, to their medical provider, to maybe decide whether or not they needed a test. And there was like a pathway where they didn't really need a test, and they had to, but they had another diagnosis, et cetera. So that piece, it's much easier to get testing now, and we do really want to encourage testing. And so no longer does a symptomatic pediatric patient need a referral from their medical provider. So I think that's helpful. So parents can just go get the test. And so that part of the algorithm we've really changed, because there may be, and I suspect there will be the majority of cases where kids can't really come to school, they may not need to even involve the medical provider. They may need to get a test. And then come back when they no longer have that cough and runny nose. I do think, again, that we're going to be seeing more things like RSV and rhinovirus and paraflu, like maybe not quite to the degree that we normally see in a non-COVID year, but I think there will be more upper respiratory infections going around this year than there were last year, where we were relatively spared from that. Again, no, like during the winter, we had no RSV admissions, no influenza admissions. So we really want to help you all with this process, because I think that is going to be a little bit different. And as always, connecting with medical providers, the pediatricians or the family medicine docs who care for the kids, we're always happy to talk a case through with you if there are questions. But hopefully that we heard good feedback about the algorithm last year, that it was helpful, and we're really trying to get the message. I put a link to a blog post I wrote, but we're really starting to prepare families for the fact that they're gonna have to keep their sick children home. And I know that's a huge source of stress for you all, because parents need to work, and their kid is kind of doing the cough and runny nose, but like running around, right? Like they're healthy appearing, but they've got this cold, and those are kids that are going to have to stay home until they're better, and that's hard. And so we're really trying to prepare families to take the heat off of you a little bit, because I know that's like a big source of stress in your work. We have some other colleagues on the call as well, who are chiming into Brina Holmes and others. So thank you for being here.
I'll just chime in really quickly. There was some questions about how to get children tested without an order if they have symptoms, and there's been a lot of discussion amongst our pediatric partners that we really are trying to take the stress off the medical homes. And so, correct me if I'm wrong, Becca, but the new algorithm will direct you to tell parents to take them to a Vermont testing site. And this is different from last year, where we were not allowed to send symptomatic people to the testing sites, but this year you will direct any child with symptoms and their parents to go get tested at the Vermont testing sites.
Yeah, that's exactly right. So just to clarify, that is a big difference from this year, where last year, if they were symptomatic, they had to get a referral from their medical provider. That's totally different now. You can bring symptomatic children to a testing center and get tested, and we can make sure you can direct parents to that, but it's right on the VDH website. You can make an appointment and then go and get tested that day. So that really changes things a lot, because I think there are going to be more kids that need to stay home from school, but probably don't rise to the level of like having to be seen in the office by their medical provider. They just need to be tested and stay home and get better and then go back to school. And so we're providing a pathway for that to happen this year. Of course, if anyone's worried about the child, they should see their medical provider just like you would before COVID. But this makes that pathway to testing a little bit easier. I think I'm going to hand it over to Brina.
Well, so hi everyone. I just wanted to acknowledge, I can't believe we're back here already together, and it's really great to see you all. And we're all here for you. The pediatric leadership of the state and the I won't be able to say new state school nurse consultant very much longer, but Caitlin Kozis and the health department team, it's like all back, and we're all here. The algorithm is a clinical decision-making tool for you and medical providers. And that got a little distorted last year, which is fine. This whole thing of COVID is just accepting imperfection. It's not meant for parents. So there is a companion document that we're updating that's going to be on the website that's really about childcare and other school, non-school programs, like for parents to think through when you don't have a school nurse. But I'm always looking for opportunity to just enhance team-based care. So you and pediatricians and family medicine folks, you have to get back in the space here of how you're going to use this algorithm for a very busy fall, because everyone is going to need to understand when to go get a test, and it's going to be sooner than last year with respiratory symptoms and even some of the other symptoms in pediatric healthcare. So I just wanted to acknowledge that this is your tool with your docs and your local nurse practitioners and physician's assistants. This is not something that we want parents posting on their refrigerator to decide what they're going to do. So, and just to echo Bill's point, you know, we're working hard to advocate that you don't have a big role in the surveillance testing of children, because we feel like, and you've confirmed this, your role, you're going to have a bigger role in this illness, keeping the virus out of the building pathway, which is, as others have said this morning, such a stressor. Parents are not going to like this. It's going to be impossible for them with their work policies and their inability to take days off. And you're going to have a lot of people trying to get their kids in just out of sheer necessity with some symptoms. So the commitment from the health department, which I don't work for anymore, but is that we're going to hear the responsiveness that if there isn't adequate testing in your community, this whole system breaks down. So that has to be real and has to be tested out. How easy are the pathways to get kids over to a test real time? And then the last thing is the algorithm is going to help you a lot, but it's not perfect, because the box of who needs a test and when still has nuance to it. Do we wait a day and let kids stay home with a runny nose, cough, fever? Yeah, you could wait a day, which is what we usually do in pediatrics, right? Wait and see. But there are going to be some kids that the docs and you guys are like, we got to get the test right now. You know, short of breath, got the coffee, but you can't make an algorithm perfect for clinical decision making. So I just wanted to acknowledge that early testing is going to have great value to community transmission knowledge. You know, if a kid has symptoms, it would be good to know sooner than later if he or she has COVID. But does every kid that has a 5-minute runny nose need a test? No. So that first day is a little tricky. And then after that first day, if symptoms persist, you're going to be recommending a lot of testing. So I see that some of our great school liaisons are on from the health department. I just think we're back to a place of needing communication tools in local communities, thinking about that bridge between medical homes and you all, and not thinking the algorithm will solve it all, but it will definitely be a guidepost as you think about symptoms and testing. So I'll stop there. Sorry to go on so long, but it's imperfect.
Raina, thank you very much for that. I think it's important. We've heard from everybody, actually, how important that communication and that relationship is between the school nurse, the medical home, the health department, the family. If it wasn't there last year, we've got to do it this year. And our leadership, educational leadership, needs to support us in that. Know as school nurses that you are supported by VSSNA, but we can only do what we can do. We can advocate for our kiddos, and that's what we're doing. And it is amazing how much work we have ahead of us in spite of being 18 months into the school district, this pandemic, as we enter a new school district. So a question that I have that came up several times pre this presentation is, how do we address mealtime in the school? And I'm wondering, Bill and Becca, I know you have opinions, and would be great if you could share those with us.
So this is Bill speaking. I believe that people should be masked in the school. I think universal masking is really important. If you are unmasked, then you should be distanced. I have a little difficulty setting an exact number, knowing the difficulty we had with the exact number last year. And that people foundered on 6 feet, 4 feet, 1 meter, 3 feet. But I think that children should be distanced when they're unmasked, and there should be architectural constraints, meaning that we should try to space them out. I think that 3 feet is really, we should try as best we can to maintain at least 3 feet of distancing. The greater the distance, the better. In some schools, this will be easier to accomplish than in other schools. So potentially in some schools, you could use the classroom and the cafeteria, but in other schools, that's not going to work very well just because there are so many students filtering through the cafeteria at different times. But I think each school will try to develop, if they are going to have masking, a process by which they can keep people distanced when they're unmasked. It'll be imperfect, but you'll do the very best that you can.
And that was part of our memo that went out to all the schools, school districts, school boards, was around paying special attention and putting thought into unmasked mealtime. I'm going to jump in and as a clinician around one question about nebulizer treatments. And I think this is a great time to think about, we know that actually inhaler, spacer, mask works usually better than nebulizers. I know a lot of families love nebulizers, but in terms of what actually gets into the kid, oftentimes we know that the spacer mask actually works better. So this might be another good opportunity to sort of reach out to family and the medical provider and say, can we do inhaler or mask spacer instead of a nebulizer? Sorry, had to add that one in.
Instead of typing, can I answer Mandy? With the Delta variant, are children generally as contagious as adults? So early in the pandemic, there was a lot of attention paid to the relative infectivity of children versus adults. Ben and I discussed that a lot. And certainly during the early part of the pandemic, we said that children were about 50% as infectious as adults. I think the key point is that children can transmit disease, and with the Delta variant, that difference may be much smaller at this point in time, but no one's really studying that at this point in time. Like with the Delta variant, we're not trying to say that children are 80% or 90%. I just think we should just accept that children can transmit the disease, and our goal is to minimize the risk of transmission in schools and elsewhere. There are 2 questions about rapid antigen tests. Rapid antigen tests are very different from the PCR tests that we've come to rely on. They look for some particles. They have, depending on which kit you use, they have variable sensitivity and specificity. And again, we talk a lot about pretest probability, and we have to interpret them carefully in the context of pretest probability. Historically in Vermont, when a person has a positive rapid antigen test, we call that a presumptive positive, but it's always confirmed by PCR. And we don't accept a negative antigen test as definitive evidence that the person doesn't have disease. So we've been cautious about their use. We use them at elder care facilities when we were screening all members of the team every single week, or sometimes twice or 3 times a week. So it makes sense if you're screening every single person, then you're just trying to find anyone that could potentially infect it. So schools in Europe have used that. So German school system used that when they would actually test every single child almost every day, looking for any evidence of the disease. That's not the strategy that Vermont has been using. And I don't think they're going to use that in the school, to be perfectly honest. I think we have been really dependent upon the PCR. We like the sensitivity and specificity of the PCR. We have rapid turnaround times that we've been getting the results quite quickly.
I wanted to address one question, and maybe Brina can also jump in on this. And this is one of the things that we really want to get included in the algorithm, and that is around maybe the single symptom of a runny nose and how to address that, because that's a big thing. So this might actually be an area where we really need some good communication with the medical home around. And so, if a patient has a new symptom, even, if it's runny nose, it's a new thing. They need to stay home and get tested. If this is a child who has, the medical home is saying that they have seasonal allergies and they feel like they have, that's the explanation for the symptoms. I think that's where the communication needs to go sort of back and forth. But I know that's a big issue with just the single symptom because that can be COVID, right? So like just a runny nose can be COVID. And again, there's just more thinking again about pretest probability. Last year we had cases in Vermont heading into the school year of the whole state of daily sort of single digit cases. And so it's just more likely that a symptomatic child, could have COVID this year than last year. So I'll let Brina jump in, but I know this particular question is sort of fraught, and we do have kids with allergies. So we need to sort of sort that out. That's part of the working on this algorithm together.
Yeah, thanks, Becca. I agree with everything. I mean, my personal approach is I think a lot of kids are going to need to be tested in the first month. And I think that sort of clinical decision making about it's always been an allergy, but it's now Delta, and we're just trying to figure this out would lead to a little bit. So the surveillance testing will help with that, because kids with allergy will get some surveillance testing and we might get a little bit better handle on that. I did want to note Leah in the chat, acknowledging obviously that not all schools have full-time school nurses, which we're always looking for opportunity to continue to push on policy here. That is the national recommendation of the American Academy of Pediatrics, a school nurse in every building, and obviously school nurse leadership, which is many of you are a part of the conversations, that this COVID thing has a small little silver lining, which is nobody should be making any decisions without school nurses at the table. That being said, Leah's right. It's hard to use this algorithm in a school without a nurse that day. And if a family is not able to talk this through with a school nurse real time, they will have to access their medical home, which is the pediatricians are positioned to do so and willing. I think there's this fascinating balance. Everybody's going to be overworked this fall, right? I mean, you're going to have a lot to process. The medical homes are going to be busy, and just making sure we continue to talk about teams and how we want this to look and flow. There's a great communication tool that Chittenden County developed that I think many of you then adopted. It's on the VCHIP website. Doesn't need to change. It's all the same facts. So please re-access that if you don't readily have that. The other piece I'm realizing when Clayton brought up the adult algorithm and we're talking about other communication tools, the health department's on right now, Nate and Caitlin, we need you to help us see which documents are not working anymore. And, we have tons of resources and we're going through them one by one. But if something's glaringly off from the recommendations we're now talking about, we're going to have to keep editing. The adult algorithm is something I helped the adult infectious disease doctors just organize it. So thanks for that reminder. Completely left my brain. So I'll get back around with that to make sure you know how to support your staff and teachers. I guess I'll stop there for now. The chat is super rich today. I think Clayton is committed, as always, to capturing it and making a nice FAQ. Thanks for all of the questions.
A question, this is more related to adults, but how do school nurses make recommendations for adults? For example, what would you recommend if vaccinated teachers are in a room by themselves at school? Should they be masked? And if vaccinated teachers are meeting for an in-service, so it'd be a larger group, would you recommend masks? Again, we have no idea how many of those folks may or may not be vaccinated, but what would your recommendation be for school nurses?
So I'll use the model we use at the Lardner College of Medicine, UVM Medical Center, that when you're in congregate settings, that you should mask, period. That is a great way to prevent infection. If you're by yourself, then you don't do your mask. Notice Becca's in her office by herself. She's not masked. I'm in my office by myself, I'm not masked. But when I leave my office, I'm putting my mask on.
I really appreciate that for myself and my own district, and I know that others will as well. Mask, 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 I guess is the message from Dr. Raszka, no matter where we are, if we see other people.
There are several masks you can use. You can even use a fancy one from the Vermont School Nursing Association that seems to work quite well. I haven't become infected yet.
That's a plug. They're still available for all of those who need some stylish addition for opening your schools. I think that question about recess was already answered. Outside is not as much of a concern. Anytime inside is a huge concern. And I like the congregate setting. If there's more than one person, we should be masked.
I saw earlier someone talking about, schools really used a lot of creativity last year in doing more things outside. And so I think continuing to, the pandemic hasn't really changed in the school setting. So all the things that we, in terms of moving things outside, I think that's great. I think, eating outside and just reminding your school leaders that activities that happen outside are great, and we should try to do that while we can.
Let me answer a question about fans, so I don't have to type. So there's a question about would fans be helpful in the school? And I do not think they're going to be helpful to prevent transmission. They may help cool the room potentially, but all they're doing is recirculating the air in the same room. And so if you want to improve ventilation, you need to actually use the HVAC system, or you need to use fans in the window. And again, we had in the Healthy Restart, we had a lot of language about that last year, about how you draw air from the outside from one window and then you push it outside through a different window. But simply having a fan in the room will not assist you in preventing transmission.
I'm wondering if any of the docs on the call can update us about singing and music.
So as you know, we had many robust discussions with the artistic community, and that I forget the national organization that talked about how you can safely sing. As you know, the most recent guidance was awfully silent. That doesn't sound grammatically correct, awfully silent versus silent, but was really silent on that. Personally, I think, again, indoors, you should, if you're singing, you should mask. I think that what to do about the instruments is really up in the air right now. I'm awfully cautious. I'm an infectious disease doctor. I want children in schools. I want children to remain in schools. I think that, the children lost so much being home last year. I want to do everything we can to have a successful start. So I would be a little cautious initially about my performing arts. If at all possible, I would again have them mask. And as you know, that with the tuba and whatnot, distancing, I think we're in a nice situation here that we can do a lot of this outdoors early in the season. It gets more complicated later in the fall when it's colder.
Also a question about return to play, and that hasn't changed. So again, I think with thinking about the Delta variant, it's again, more children are getting infected, but how it's sort of affecting people is not any different. And so we sort of think about it in the same way. I don't know if anyone else has thoughts about return to play, but that won't have changed.
There's an interesting question. Actually, I should say all the questions have been really interesting, to be honest with you. This is so much fun for me to read these insightful things. But a boarding high school with day students and faculty and a vaccination rate above 90%, is masking still as necessary? Well, if you believe that you can achieve herd immunity, then you would say, I'll just be honest, then no. That if you really believe that everyone is immune, or as close to that as possible, then you would say that masking is not as essential. I would just say that there are breakthrough infections. There are still complications, but if you just look at, and there's these are not, transmissibility, what you need for herd immunity, then you could make a rationale that school would not have to mask. That's probably where that 80% rule came in when we were thinking about herd immunity with the original Alpha variant or the original variant in the United States. That's a slippery slope. Kathleen, cleaning of surfaces last year was part of the mitigation strategies. I think you should wash your hands. I think maybe at the end of the day, you should clean the surfaces and the doorknobs. But I would much prefer that we spend our time elsewhere. Again, routine cleaning works very well. I really hope that we can get away from the concept of deep cleaning. The deep cleaning is a fallacy. Please do not use school resources for an entire Wednesday dedicated to scrubbing the building. That I don't think is an effective use of time and resources.
I'm wondering if you can address the issues of isolation rooms. We had them last year, obviously. Brina, go right ahead. Looked like you were ready to answer that.
My answer was to get Caitlin on the camera. Caitlin's been working on that, and I'm not updated. Obviously we really like the isolation room policy, but the answer is in the chat. Look at Nate. Nate has become quite skilled at chat answers.
Thank you. That is a question that comes up a lot.
Yeah. Well, I'm not aware. We do that noon call, as you know, and we read out all the chat all the time because we do know a lot of people call in. And so it's just for that particular answer, I just want to make sure people know that we stand by, from a public health perspective, the recommendation to keep a space preserved for students in the fall. So I like that because I think that gives you the language that you need to then, you may recall I was a health teacher for a few years, and I know that space in schools is a hot topic. I also know some principals gave up their office for isolation in some districts. So let us know how we can help if that's not enough.
Brina, I'm wondering if this might be a good opportunity for you and Wendy and Becca and Bill to highlight the partnering that VSSNA and you have been doing with VCHIP calls, addressing the 3 hot topics on Wednesdays.
Well, sure. I guess I just want to shout out the VSSNA board because your ability to sort of continue to grow and partner and keep being strong leaders for this incredible group of people is it takes a lot of work and in a volunteer capacity on top of your school nursing responsibilities. So, I mean, the whole thing shifted. It actually shifted back in June that this is not a public policy, this is not mandate, executive order, government involvement anymore. This is pediatric medical advice to school districts who care about kids. So the natural progression of that is that your connection as an organization now needs to be with pediatric leaders and infectious disease specialists, not really with state government. But that said, MCH, maternal and child health, and the state school nurse consultant has always done a beautiful job bridging that world. And you need Caitlin in the center of this because some of this will be public policy, even if it's just the surveillance testing. Great example last week, Becca McCrae said, this is kind of news to us that school nurses are called out as potentially a workforce to do testing of children of a certain age. So we brought that back to public health. Caitlin elevated it and was able to get folks to say, no, kids can swab themselves. Maybe their parents can help, as Becca Bell noted earlier. Maybe someone else can get it done. And then if there's really a recalcitrant, if there's a situation where it's not going to get done without a clinical provider, I know you all as great school nurses would swoop in, but you don't need to be the first line. So that's the kind of balance between you need your pediatric leaders, but you also need your state government folks still to see where there is an opportunity to change something that's going on in the agency. So I just think there's going to be a lot of these. You know, Caitlin set up a great town hall for you next week with the EPI team. You still need them. My goodness. I'm so glad we're still committed to contact tracing. You know, a lot of states have opted out of that for schools and go quickly to, as Bill noted, the endemic situation where we just have COVID, and we're not ready to do that in Vermont yet. And I'm grateful because I think we need to get through Delta here. So, and then these calls, you know, Wendy had to leave. She's not on, and she might think this is, might break the capacity of the call, but you guys are all invited to join the noon call. They're currently only Wednesdays, but we're planning to add a call per week in the fall for a lot of this. Your pediatric colleagues are on, your health department folks are on, and many of the school nurses have joined. Because there's actually 5 things, and I can put it in the chat, that we feel you fed back to us, especially through Caitlin, the hot topics. I mean, you need still time and space to do COVID coordination. You need that algorithm updated because illness is the biggest thing on your mind. You need to understand contact tracing because the communication about that is coming, but it's not here. You need to understand this surveillance testing thing because you've been implicated. And then I think the 5th thing is that you're, wondering about this masking thing and need that pediatric support. And I put this in the chat earlier. Email Stephanie Winters if you need a pediatrician to go to your school board. Email Stephanie Winters if you need a pediatrician just to talk to, because your local pediatricians are activated, and family medicine folks. We want to make this pediatric medical advice and not have you in a big political morass. And then, of course, Nate, as he always does, is putting in the link for you on how to get on the VCHIC call today at 12:15. Hot topics, schools, schools, schools. I'll stop there, so thanks.
Thank you. I just want to make another shout out. Our colleagues at the American Academy of Pediatrics here in Vermont are incredible. Later this afternoon, I believe, is the Facebook Live presentation on vaccines with Dr. Becca Bell and Dr. First. So share that with your communities. And I'm glad I'm not in school right now because there is so much information that I want to grab from all of you before we move on.
I have a text from to discuss what to do about overnight camps or overnight events. I would generally say I am not thrilled about school-sponsored overnight trips. Camps that did that this summer had a pretty rigorous process that anyone who was eligible vaccine generally had to have a vaccine, had to have proof of vaccination, and then to enter the camp that you had to have proof of a negative PCR. I was actually involved in a camper who was driving, but and literally they had real protocols. Like you got tested, you had to be isolated until you arrived to camp, and someone broke the protocol and had an exposure, they wouldn't let the camper in. So I would be really cautious unless you can assure that they're all immunized and they'll have a negative test before doing this. That just sounds like a possibility for transmission. If you're sleeping overnight, you're not going to wear your mask. There's increased risk for transmission.
We have just a couple of minutes left, but I'm wondering, this visitors in the school building or at the schools has been a question that's come up several times over the past few weeks as we're looking to opening schools. So you could address that question.
I think anyone who enters the school should be masked. And that should be basic policy. I don't think you would necessarily require proof of immunization to enter the school, but they should all be masked.
Thank you very much.
I would also want to address, Diane talked about the difference between high schools, which last year were really at hybrid 50% capacity, now full capacity. And this is another opportunity to really highlight and emphasize the importance of vaccination, because in the high school environment, right, everyone's eligible. And we do have in Vermont, we lead the nation in a lot of things, including our adolescent vaccination population, which from 12 to 17, about around 70% of that age group is vaccinated, which is, there are some parts of the country where it's like 30%. So that's great. And I think it's just another way to emphasize the importance of vaccination in that population, because that is, everyone's eligible. And when we're talking about a potential exposure, there's a big difference between when you see the algorithm between someone who's vaccinated and they're exposed and those who aren't. And so hopefully as part of the process, if there is a COVID exposure, that kind of highlighting and emphasizing, those who are vaccinated can come back to school, those who aren't cannot, or they have to wait.
There was a question in the chat about if we should be screening visitors when they come in about symptoms.
There's a general guideline that no one ill should enter the building, period. Beyond that, I don't think that you're going to be actually screening them. That you're not going to be keeping a record of it, but there would be a sign: if you're ill, you should not enter.
Regardless of what those symptoms might be.
Regardless, I don't want anyone ill in the school. There are a lot of other respiratory viruses. Now, clearly, if there's chronic illness, I have chronic joint pain, can I enter the building? That's someone who's really teasing you a little bit. I'm not worried about that. But anything suggestive of an infectious, contagious disease, then they probably shouldn't enter.
I kind of want to join next week and listen to the EPI team, because there's so many good contact tracing questions that you all have in there, and I have them too. And so, I think with this partnership that we have, which is so great, that we get this like general idea of like what should be done theoretically in schools. And then I feel like, sometimes when we hear that from the state, we, as those of us who work with kids, can think of what the practical implications are of this and try to give our input and help. But then you all are actually the ones in the school doing the work. And so we really want to hear from you what your experiences are. And it'd be helpful for us to learn too about the epi tracing. So I think some of us might join next week just to listen.
That's okay. You are always welcome to join. You have all of our emails in case you don't get a specific invite, because we do require registration. You also have our phone numbers, most of you, because we've been able to develop this amazing teamwork approach to addressing the needs and concerns of our students, our school, and our community. And I just can't speak to that enough. I am speechless at how much has developed, and this has been an incredible experience. Dr. Raszka, Dr. Bell, Dr. Holmes, so appreciative of your joining us today. And our public health colleagues, thank you so much for joining us as well. And we'll get the invitation out soon, and we hope to see you all next week. And if you're already starting school, mask up. Thank you all so much. We really appreciate it.